So for the common femoral artery, as you know, there are two general options for treatment. The first is the traditional common femoral endarterectomy, which has great durability, but as you all know, does have some drawbacks to it, including wound complications, dehiscence, infection, paresthesias, and so forth. The other general option is the endovascular approach, which includes angioplasty, atherectomy, and stenting. Tries to improve upon some of those drawbacks on the endarterectomy side. However, there are some questions about long-term patency and durability, and also there are issues with the placement of a stent in this area, which is very dynamic and can lead to intimal hyperplasia, stenosis, and occlusion potentially. And then often this technique is used in a hybrid setting with endarterectomy of the common femoral and then stenting of the iliac or the SFA at the same time. In terms of societal recommendations, so the Society for Vascular Surgery in 2018 really doesn't have any specific guidelines for a common femoral artery isolated disease, but they do note that it's a first-line treatment if there's significant stenosis in the common femoral artery in a patient who you're planning on fixing their aortoiliac occlusive disease. Additionally, they do recommend it as a hybrid procedure, combining that along with iliac stenting for combined iliofemoral disease. The AHA-ACC guidelines 2016 favored considering surgical revascularization for lesions involving the common femoral artery, especially if they're including the origin of the profunda. And the FCAI in 2018 recommended endovascular therapy, given the high technical success, improved safety, and comparable patency of this technique, and they recommend bare metal stenting, drug-eluting stenting, and/or DCB as a Class 2A recommendation, as they state that these devices are reasonable, useful, and beneficial. So one study I wanted to dive into, this is a review from JVS in 2016. So they looked at 655 patients who underwent this procedure over 6 years. The distribution was about 2-to-1 claudication versus CLI. The patency for this procedure at 3 years, primary was 90%, secondary was 98%, though there were procedural complications in the 7 years follow-up at 11.5%. So going into some of those complications, this was another study that was done, review again in JVS in 2015. This is a NISCOP review of 5 years of data of isolated endarterectomy cases, 1,800 patients. Mortality was 3.4%, 30% of which occurred after hospitalization, and there were wound complications, 8%, the majority of which happened after discharge, with a combined morbidity mortality of 15%. And then the final study in this area that I wanted to point out, this is a very recent study in the Scandinavian Journal of Surgery in 2020. This is comparing the outcomes of endarterectomy in patients above the age of 80 and below, which is something that perhaps can lead to greater, worse outcomes. So this is a review over 11 years. They compared the two groups of patients, 977 patients. Obviously, the survival was less in the over 80 group. However, the mortality in 30 days was almost 8%. 30-day major amputation rate was 3%. Lymphatic and wound infection rates were also higher, and these were all statistically significant. And you can see from the data here that there are some reasons for why that may be the case. There was a greater rate of CAD in the above 80 population, as well as hyperlipidemia, statin use, which was less, smoking, renal insufficiency, obesity, and then a higher proportion of rest pain and tissue loss. In addition, in the older population, there was a greater proportion of patients having this done, but also having endovascular treatment of a distal artery, and there was a greater proportion of higher risk candidates, essentially, ASA4. So in summary, endarterectomy is still first-line therapy for the majority of patients with isolated disease in the common femoral. However, careful patient selection is crucial, and the numbers that we typically quote our patients are there's a less than 2% perioperative mortality, there's a 5 to 10% risk of major and minor complications, but long-term, generally speaking, there's greater than 91% primary patency. Moving on to the endovascular subset. So this is a review in the JVS as well. This is a VQI query for 5 years, 2010 to 2015, for all interventions done on the common femoral artery with or without profound intervention. 1,000 patients, mostly claudicants. The periprocedural complication rate was 5% for axocyte hematomas, 3% for dissections, and then less than 1% for distal embolization, axocyte stenosis or occlusion, or perforation. 30-day mortality was low, 1.6%. Freedom from loss of patency or death was 83% at 1 year, and then 87% reintervention-free survival at 1 year as well. This is a comparative study, again, in JVS comparing drug-eluting balloon angioplasty versus endarterectomy in common femoral disease. This is recent in 2019. So they reviewed all patients who had symptomatic CFA disease over a 3-year period. They identified 100 patients, 40 with DCB, 60 with femoral endarterectomy. So the results were all patients had technical success, but there was a distinct difference in primary patency as well as secondary patency at 1 and 2 years, with greater numbers for the femoral endarterectomy group, as you can see, as well as freedom from target lesion revascularization at 1 year, 96%, and then 94% at 2 years. And then the final study I have here, this is a randomized controlled trial, which is a great thing in this space to have. So this was a French study published in 2017 in JACC, comparing bare metal stenting to surgery for de novo common femoral artery stenosis. So their primary outcome was morbidity and mortality in 30 days. There were 117 patients that they randomized to surgery or stenting. The primary outcome of morbidity and mortality was reached, or mortality, I should say, in 26% in the surgical group versus 12.5% in the stenting group, and that was statistically significant. And there was a higher length of stay, obviously, in the surgical group, but they did note that the primary patency and the TLR rates were not different in the two groups at 2 years, which was very interesting for this study. This chart is showing you the difference in the rates between the two groups with both the intent to treat analysis and per protocol analysis. There were greater rates in the surgical group versus the stenting group. And then here shown the Kaplan-Meier curves, A being death from any cause, B and C being freedom from any revascularization, either lesion or leg, and then D being the primary patency. As you can see, there's no difference in stenting versus surgery. Some limitations on that study, though, to note. There's 117 patients, which a little on the smaller side. Additionally, 112 of them completed the 30-day follow-up, but only 86 completed the 2-year follow-up. So there's some question whether or not 2 years is long enough to really have a true comparison. And then for endarterectomy, they noticed 82% primary patency, which is less than the typical quoted numbers in the literature. So endarterectomy is still the gold standard for common femoral intervention, but it's very important to take into account other factors such as patient age, other comorbidities, lesion anatomy, calcium morphology, eccentric versus concentric, prior surgery in the area, and then a future need for the access site for a PCI or for a TAVR, for example. Angioplasty alone has the highest recurrence rate, but it doesn't negate or complicate the potential for future procedures. Stenting has great long-term results, but it can make future interventions more complicated, not impossible, but more complicated. And then atherectomy cameras are also in good long-term patency without adverse impact on future options. However, there is some question about obtaining optimal luminal gain in a larger CFA, and there's some risk of perforation or distal embolization, though less than 1% as we saw. Ultimately, more studies are needed with these newer devices over longer periods of time to be able to accurately compare to endarterectomy, such as the PESTO AFC trial, which is coming out. It's enrolling now, I believe, and it's going to be DCB versus and atherectomy versus endarterectomy. And that's it. Thank you.
Thank you. So, any questions for Dr. Fair?
You mentioned that the access site would be an issue. How would that hurt the future access for PCI or not?
Sure. So if you place bare metal stent, it's still possible to access it. With the placement of the stent, there's some question of closing the access site after you're finished, as well as getting larger devices in there. That's one concern.
Okay, so he mentioned the PESTO study. Tomorrow, Dr. Zeller will be presenting the interim results of the PESTO study. I know he presented it at the last meeting, and I think even at Viva. So I don't know if you guys missed it. So tomorrow, definitely you'll be hearing some more update on that particular study.
All right, beautiful. All right.
Thank you.
Thank you so much.
Thank you very much.